bottom number is what is going to be changing. So the bottom number tells you at what distance the normal eye can see the letters. So if it's at 20/20, it means that the normal eye can see these letters at 20 feet. But as the number becomes bigger, as you can see, this refers to what the normal eye can see at that distance. So obviously, a normal eye can see the larger numbers here at a further distance. Like right at the top here, 200 means 200 feet away, a normal eye can see it. But if the patient can only see it at 20 feet, then it will be 20/200. That will be his visual acuity. Now, visual acuity can be measured in feet or converted to meters, depending on the country, because some countries prefer different ways of different metric system. And there's another way of measuring visual acuity so how is it represented? Sorry, I'll show you how it's represented. So it's not always often that you see like just 20/20 or 20/25, right? That sometimes you see a little number that's indicated beside the VA. Now that just tells you that the patient is able to see 20/20 except for one alphabet that's missing in that line. So it's not a perfect 20/20, but a little bit less than perfect. There's also possibility they can write visual acuity with a plus number behind, like 20/30 plus 2. So that plus 2 means that the patient can read an additional 2 lines on the visual acuity chart that is above, below it. Like on 20/25, you can probably read 2 more letters on it, in addition to the 20/30 line. So that plus 2 or minus 1 represents something that is in addition to the visual acuity that's indicated. Now,
2 lines or 2?
Sorry, two letters, not 2 lines. 2 letters extra, in addition. Yeah. Now, sometimes visual acuity it's measurable up to 2200, but sometimes if the visual acuity is really very poor, for example, the cataract is really very mature, then you may have a situation where the patient can't even produce a 2200 PA. In that case, they may use other ways of measuring the visual acuity, like bringing a handheld chart towards the patient and then asking the patient if they can count the fingers on the surgeon's hand. So the optometrist may put out his hand and then ask the patient to count the number of fingers that he is showing on the hand. And then hand motion, whether they can visualize hand motion, light projection, whether they can discriminate where the light is projecting from for example, from the left, the right, or from the top or the bottom. And light perception is whether they can even perceive any lights coming towards them. So these are some other ways of indicating visual acuity. So sometimes, if you see that the surgeon has indicated CF on the patient chart, that means counting fingers, or HN, LP, that can mean light projection or hand motion. So those are just some other ways of indicating visual acuity besides the Snellen acuity. Okay, now visual acuity would also be affected by the dryness of the eye. So if the visual acuity is affected by dryness, then it needs to be continuously being lubricated, all right, to improve the visual acuity. But of course, dryness if the visual acuity is fluctuating a lot, that's also a clear sign of dry eyes, that the patient may have some problem related to dry eye problems. For visual acuity, it's common to also show visual acuity not just in Snellen format, but also in other forms like decimal. So decimal is quite popular in some markets, right, where they take the numerator and divide it by the denominator number. So if you have 20/20, then the decimal equivalent is 1. Visual angle is not so common, but sometimes they use it. It's 1 divided by the decimal equivalent. And logma is also based on the decimal equivalent. However, you do a negative log to get that value. So how does it actually look? This is a conversion chart. So if you look at like a 20/20 vision for Snellen, that equates to a decimal of 1 and a logma of 0. So there are just different ways to show the visual acuity, and it's in some cases there's a preference towards using logma or decimal, especially for logma, because the steps in terms of the increments and the decrements, it's consistent. So they like to use logma when it comes to some kind of analysis in terms of statistics rather than Snellen. So an example, just show you an example. I think you've seen this chart before. So this was the recent clinical data shown for IHANS, and you can see that you've got Snellen acuity on one side here, but at the same time, we've also shown the logma acuity on the other side. So as you can see, there is a correlation of Snellen and logma, right? Just different ways of representing visual acuity. Alright, and for visual acuity, there's also another measurement for near acuity. So for near acuity, the standard distance is usually at 35 centimeters, and that's a chart that is calibrated for that distance. So just bear in mind that when you are using when you are measuring the visual the acuity at intermediate, the chart size needs to be recalibrated to that distance. So at intermediate, that chart needs to be, the size of the letters needs to be bigger to accommodate for the intermediate acuity. So you can't use like a near acuity chart to measure your intermediate vision. It needs to have a different chart for intermediate acuity. Now, to measure near or intermediate acuity, they usually use a Jaeger system or point system. Point system is what is commonly mentioned as an N3 or N5. I think you may have heard of that being mentioned by your customers, or Jaeger 1 to Jaeger 10, right? So point system, it's based on a system of printing the print size based on the Times New Roman font. So if you look at the Jaeger score versus the point score, a J1 score is equivalent to N3, and that's 20/20. So if you look at N5, you're looking at 20/32, and a Jaeger score of about J3, right? So those are the different variations of near vision measurement and representation. Of course, near vision can also be represented in terms of Snellen acuity. So sometimes we may even represent the near vision in terms of its Snellen equivalent rather than Jaeger or point system. Okay, so that is my recap of visual acuity. I hope that helps. Now I'm going on to diagnostic other diagnostic equipment. So the other diagnostic equipment is relating to, for example, Fundus Exam. So for Fundus Exam, this is to evaluate the posterior segment. It's mainly to look at the macula, the optic nerve, right? So the retina, to see if there are any issues with the back of the eye. So for Fundus Exam, there are two ways to perform a Fundus Exam. So one is a direct ophthalmoscope, which looks like this, right? And basically what the examiner does is it points it into the eye and looks through the other side. I'm going to show you a video that demonstrates that. So I hope you can see my video. Right, so that helps the doctor to be able to see the back of the eye. The other way to examine the fundus is also using a indirect ophthalmoscope, right? So an indirect ophthalmoscope looks very different. There's a pair of binoculars, and then there's also a high magnification lens that the surgeon is holding, right? And with these two instruments, is able to look into the back of the eye. The difference between an indirect ophthalmoscope and the direct ophthalmoscope is that this has a wider view of the back of the eye. So basically the surgeon can angle himself at different positions to look into the different parts of the retina. So not just the central part of the eye, not just the central part of the posterior segment, but also the peripheral parts of the retina as well. So let me show you a video that demonstrates that. So this is what they are observing, right? The back of the eye. Yeah. Basically, the surgeon has to put up binoculars here and apply magnification lens and shoot back. All right, so that's for the Fundus Exam. I'm just going to go to the patient case notes to give you some examples of how it will look in the patient's case sheet. All right, so this is an example of a patient case sheet. And if you look at the pages, like the last page here, it shows you Fundus Exam. So it may not look exactly the same in those charts that you happen to be able to see, right? But basically, this shows you whether it's an indirect or direct ophthalmoscope that's been used. And then it shows you what is the status of the back of the eye. So evaluation of the macula, the vitreous, P, I'm not so sure what's that, but it shows that it's within normal limits. So the back of the eye basically is healthy. CD represents the cup disc ratio. So sometimes they evaluate the size of the cup of the optic disc versus the actual disc to see what is the ratio. Usually if the ratio is very high, it's like more than 1/3 of it, there is a higher risk of this patient having glaucoma. So that's how the fundus exam is going to be useful. The other, I think I didn't show you this earlier on, but visual acuity can be represented in this form, right, in the patient's chart. So you can see the right eye and the left eye, the visual acuity is 20/80 for the right eye, 20/40 on the left eye. So obviously, right eye having a little bit more problems. CC here, what I understand, represents visual acuity with with spectacle correction. SC represents visual acuity best corrected. So having best corrected visual acuity, right, versus uncorrected visual acuity. Now there's something that we, I did not mention earlier on. Visual acuity can also be represented as best corrected and uncorrected. So that's going to be important for us to take note of as well, because let me get to this. Best corrected visual acuity is the visual acuity that you can get with the spectacle correction. So that's the best corrected that you can get. And uncorrected visual acuity is visual acuity that's without correction. So without spectacles or without contact lenses, what is the uncorrected visual acuity? Now for best corrected and uncorrected visual acuity, this is tested before the patient goes through cataract surgery and also done after cataract surgery. What is going to be more relevant to evaluate the performance of IOL? You need to look at both. I mean, but most of the time, if you're looking at how well the IOL is performing, you probably want to be looking at best corrected visual acuity, because this takes away all the refractive errors that may be a result of the surgery. All right. So, for example, if the incorrect lens power is being used, the visual acuity can be affected by the refractive error. So that may not give you the actual performance of the lens. So you may want to use the best visual acuity to get a better idea about the performance of the lens. So for uncorrected visual acuity, that's going to be inclusive of any refractive errors that happen due to the selection of the lens, due to calculation, due to measurement errors. That is all included in the uncorrected visual acuity. Now, best corrected visual acuity is also going to be important when you are measuring near vision or intermediate vision. So, for example, if you are measuring near vision at a certain distance that the IOL is supposed to be able to provide, then you would be better off to do it at the best corrected distance visual acuity. So before you measure the intermediate vision or near vision, you want to first best correct the distance VA before you measure the near or intermediate vision. Because at that particular distance that you're measuring near or intermediate, that is assumed that the patient is at emmetropia. So sometimes when you look at the visual acuity performance, so for example, this one, yeah. So, for example, in the evaluation of the eye-enhanced visual acuity for intermediate, that is done with best corrected intermediate VA, distance corrected intermediate VA. So meaning that they have best corrected the distance to emmetropia before measuring the intermediate vision. Right, so this takes away any refractive error that's associated with the IOL power that's implanted. Now, uncorrected intermediate VA here means that it includes whatever refractive error that is induced by the IOL that is not being corrected. Right, so obviously you see a difference in the results. So for example, if you look at the distance corrected intermediate versus the uncorrected intermediate, there's always going to be a difference here. All right, so this uncorrected intermediate VA seems to perform a little bit better than the distance corrected VA. So likelihood that there may be a little bit of myopia that's been induced that results in a higher visual acuity result, a better visual acuity result compared to the distance corrected intermediate VA. Okay, sorry for moving back to VA because I think there were some things I missed out. Okay, so Slitlamp Exam. So Slitlamp Exam, it's more to get an idea about the eye health based on the anterior segment. So from the cornea all the way through to the lens, they are able to get a examination. So in the case of cataract patients, it's also to evaluate how mature the cataract is, right? So when you look at a examination of their slit lamp, so for example in this patient, right, it shows that the conjunctiva, the cornea, and the anterior chamber all within normal limits, as what's indicated here. Iris as well, and then when it comes to the lens, the crystalline lens, not the IOL, so this is obviously a pre-op examination with the slit lamp. You can see that there is some cataract already forming, and this just represents the maturity of the cataract, so it represents a 2 to 3 plus nuclear sclerotic cataract that's present in the patient. So obviously the right eye has got a little bit more cataract than the left, right? So the left eye has some cataract, but a little bit less mature than the right eye. Alright, so basically it looks at the anterior segment, and to evaluate the posterior segment, you cannot do it just with the slit lamp itself, but some surgeons would use some practice would use like an additional lens that is able to look to the back of the eye together with the slit lamp. So basically they will hold up another lens towards the cornea, and then using the slit lamp together with that lens, they can possibly observe the posterior segment or the fundus of the eye. Okay, so I'm just going to move on to refraction. Now for refraction, it is ways to measure the eye to evaluate what is the refractive error, right? So to check refractive error that's can be due to myopia, hyperopia, or astigmatism. Okay, so there are two ways to measure. There are two ways to do it. One is an objective measurement, which doesn't require the patient to provide a response. So that is either using a retinoscope, right, or a autorefractor. So I don't have a picture of autorefractor here. Yeah, so or a autorefractor. So the autorefractor, it's a very easy to use instrument. You just get the patient to look into the instrument, and then they click on the button, and then it measures the refractive error. It's much quicker than the retinoscopy. But for retinoscope, it is useful for some patients that are unable to cooperate to look into the instruments, or they are not able to sit up, and then a retinoscope could provide some form of objective refraction. So how this works is using a slit of light and shine it into the patient's eye. I'm just going to show you a video that demonstrates it. So basically what happens is that he's going to hold a retinoscope here, and then he's going to shine a slit of light into the patient's eye, and then he's going to move that slit of light sideways from side to side. So the objective is to look through the patient's the eye and see the reflex on the back of the eye. Now, if the patient is perfectly emmetropic, that reflection will be static. But in this case, when you see that there's hyperopia, and when you're swinging the light back and forth, what happens is that you see the reflection at the back of the eye moving in the same direction as the movement of the retinoscope. So they call this whiff movement. So if it's a whiff movement, that's actually hyperopia. There's hyperopia induced here. Now, as you improve the refraction and you achieve emmetropia, now that light is not shifting anymore. And so if the light is static in the eye, if the reflection is static, then it's emmetropic. Now, if you have myopia, then it becomes opposite. Now, when you swing the light back and forth, you get a gaze movement. So when you swing the light to the right and the image moves to the left, towards the left, then that is a gaze movement. So that means that there is myopia. So this is what it looks like at the front. So if you're moving the light towards the left here, and the reflex is moving together with it, right, together with the swing, that means there's hyperopia. And what he's doing is that he's trying to correct it with some plus lens, and there's still some hyperopia, as you can see here, because it's moving together with the light, and then eventually, but you can see some improvement because the light beam is a little bit wider, and now he's correcting it even more, and it gets wider again. So there's some correction happening, but not sufficient to fully correct it. Now, eventually at this correction, you see that the light is not shifting anymore. So this is where the patient is fully corrected to emmetropia. And here, you can see the gaze movement. So this is where myopia is happening, right? Because with too much plus power, we are in fact inducing more myopia. So that is the mechanism of using a retinoscopy, right? But you need, in addition to the retinoscope, some trial lenses in order to determine what is the refractive error. So trial lenses are lenses that are looking like this. Alright, so these are trial lenses. Right, so in order to perform retinoscopy, you also need trial lenses or a Phoropter to do it. So you need to use different power lenses to place in front of the patient's eye and swing that retinoscopy light across it to make sure that the light doesn't move with or against. Right, so then you need to combine the retinoscopy with the trial lens or the Phoropter. Yeah. So that's objective measurement of refraction. And of course, there is also the subjective measurement. So subjective measurement requires you to use either a Phoropter or trial lens. So this requires the use of the instrument together with the Snellen chart. So the patient needs to be able to see 20/20 on the Snellen chart to determine that the correction is up to emmetropia, right? So they just need to flip the lenses into the vision of the patient, so that, and then the patient needs to read out the Snellen chart and be able to achieve 20/20 on the Snellen chart. Okay, so there are different lenses that can be put into the vision to be seen by the patient. So you have spherical lenses, and also you have cylinder lenses that can be put into the vision of the patient. Okay, so how does that refraction look on the patient chart? So typically it looks like this. Right, so you have refraction here, and you notice that there are different refraction values that has been reported here. So AR means auto-refractor, which is the objective measurement done. The manifest refraction and cycloplegic refraction are done with the subjective refraction tools like the trial lens and the Phoropter. Right, so you will notice that there's some difference in the refraction that has been measured simply because of the difference in the instruments. Usually for objective refraction using an auto-refractor, the measurements are more myopic. So you can see here in the form of the results, the auto-refractor readings here are more myopic compared to the manifest refraction, subjective refraction here. And you can see in terms of by using the spherical equivalent power. So spherical equivalent power is using the sphere and adding it onto this half of the cylinder. So in this case, if you add the sphere to half of the cylinder, that comes up to about minus 8 diopters of spherical equivalent. And here, when you add the sphere to half of the cylinder, this comes up to about minus 0.25 diopters. So obviously, the auto-refractor measures more myopia compared to the manifest refraction. Now, there's also a difference between manifest refraction and cycloplegic refraction. So the cycloplegic refraction is performed when you have used some kind of pharmaceutical agents to paralyze the accommodation. So it can be some kind of gel, right, or eye drops that's used to numb or stop the accommodation, and that measures the refraction without any contribution of accommodation from the lens. Now, cycloplegic refraction is quite important, especially pre-operative for younger patients or for children or for hyperopic patients, because these patients tend to accommodate even for distance vision. So in order to get the correct distance vision refraction, you need to use a cycloplegic refraction to give you that most accurate result. Of course, when we look at IOLs, we don't perform cycloplegic refraction post-op after cataract surgery because there's no longer accommodation in that form. But manifest refraction and auto-refraction could possibly be done post-operatively. So there's another there's another instrument that's used to measure eye pressure, and that's tonometry. Tonometer is used to measure the intraocular pressure in millimeters mercury, and this is used to diagnose glaucoma. So extremely high pressure is an indication of glaucoma that could happen, some of these instruments, like this one, it's a Goldman tonometer. It's attached to the slit lamp. It's moved towards the patient, and this part of the tonometer touches onto the patient's eye. So there's actual contact with the patient's eye. But some of the other tonometers that's used nowadays can measure eye pressure with a puff of air onto the patient's eye. So there are alternative tonometers available as well, but they all use to measure the eye pressure. So just to give you an idea of how it looks on the patient chart, right? So the eye pressure indicated here in terms of T represents tonometer reading, 16, which appears to be normal. So between 12 to 18 millimeters mercury is what considered to be a normal intraocular pressure. Right, so tonometry is measured, is performed before surgery, right, to do screening for certain eye conditions. Tonometry is also done after surgery, after cataract surgery, to check for eye pressure. So in case there is intraocular pressure spikes after surgery due to OVD that's not completely removed, this is a way to take that measurement and to get an idea about whether there is excessive pressure spikes in the patient. So it is not good for excessive pressure spike, because that causes a lot of patient discomfort. Okay, a lensometer is an instrument that's used to measure the power of spectacle lenses, right? So basically what you do is you put the spectacle lens onto this instrument, and it's able to give you an indication of what's the power of the spectacles. So a indication of that in the case sheet looks like this. So they would have some kind of refractive power indicator. It looks like refraction, but it is indicating the actual power of the patient's spectacles. So the sphere power, the cylinder power, and the axis of the cylinder. And this spectacle is worn for 3 years. It has an add power of +2, so it's a bifocal lens that has some additional power for near vision, right? And so that's what the patient is wearing. Keratometry, it's measuring the corneal power. So there are different instruments that can perform this. So there are basically two types of instrument. One is a manual type, where the technician needs to turn certain dials on the instrument to get the measurement. There's another way, it's an automated method, which can be performed with an IOL master, or even the lens star, and even auto refractors like this. They also offer the keratometry measurements as well. So so they can measure the central corneal power. So there is some difference between the two instruments in the area of its measurement. The manual keratometer tends to measure a larger surface area of the central cornea, up to 3.2 millimeters, whereas auto keratometers, such as the IOL master or the auto refractor, they measure a smaller area of about up to 2.5 millimeters. So the difference in the area of measurement does contribute to slightly difference in the measurements that you see recorded on the patient's case sheet, right? And you can see it here. if you look at this patient report, right, it's got three different keratometry readings. So this one here is performed by the autorefractor. So you've got the K readings performed by the autorefractor, and then at the bottom of the case sheet, it does shows that manual keratometers is also performed, and you can see that it's quite different in terms of the readings compared to the manual, compared to the autorefractor. So there is some difference, and even the IOL master also has got some keratometry readings here, which is also slightly different. So in this case, the IOL master K readings correlate actually quite well to the manual K readings. Yeah, they correlate quite well to the manual K readings. Yeah, it's quite similar, but the autorefractor K readings are quite different. This helps the practitioner to think about whether to do some repeat measurements. So if the keratometry measurements are very different for the instruments that are being used, they may choose to repeat the measurements, right? Because they may not be certain which ones are more accurate. But most surgeons have a preferred keratometry method, so they may have a preference on the IOL master K, or they may have a preference on autorefractor. Sometimes they may have manual keratometers, but not many practice do have manual keratometry in their clinics. Another advantage to manual keratometry is that the technician actually looks through the optics here and looks at the reflected mires from the patient's cornea. So basically how the keratometer measures the cornea curvature is to look at the reflection of the mires onto the patient's cornea and turn the dial so that the mires are matched up. But by looking at these mires that's reflected off the patient's cornea, if they see some kind of wavy structure or irregularity, or they are not so clear, that also gives them some idea about the status of the cornea. There could be some kind of irregular astigmatism, and so for the technician using a manual keratometer, it has a little bit more added value if they are trained to be able to observe the reflection of the mires of the corneas of the patient's cornea. Now, corneal topography also does measure keratometry in a way, but it doesn't do it in the same way as keratometry. So keratometry does direct measurement of the central cornea, but corneal topography measures peripheral parts of the cornea. It cannot measure the central part of the cornea as accurately because it has a camera that is located at the center. So there are no Placido rings in the center that's able to measure the cornea center. So how it achieves the keratometry is by using a simulation of the K readings based on the curvature of the cornea from the periphery. They extrapolate the values to the center and then provide a simulated keratometry value. So a lot of surgeons may use the topography, but not so much to obtain the K values for IOL calculation or toric IOL calculation, but more to evaluate to see if there is any cornea irregularities that cannot be picked up by keratometry. So keratometry, especially auto-keratometry, is not able to pick up irregular astigmatism. It will just give you a number. It will not be able to give you information about the shape of the cornea. So only the topography is able to give you information about the shape of the cornea. In this case, it's a regular shape, but sometimes you see like a irregular shaped cornea where the hot zone or the red colors are focused on just one part of the cornea, right? Or it may look like a claw shape rather than a bow tie shape. So those are irregular type astigmatism, which cannot be corrected by conventional ways like spectacles or toric IOL, right? So it's important to be able to screen out these patients, because otherwise it may give a surprise when you're thinking you are correcting regular astigmatism, but in fact the patient has irregular astigmatism, and the results post-op after implanting a toric IOL doesn't seem to correct the astigmatism, or the astigmatism actually becomes worse off. Okay, so in biometry, so biometry is the measurement of the axial length of the eyeball. So mainly the axial length of the eyeball is what we are looking for, but biometry is actually measurement of length. So it can be lens thickness, it can be the axial length, it can be the anterior chamber depth, and even the horizontal white to white. For some instruments like the IOL Master provide the measurement of the horizontal white to white, which means the cornea diameter. So from this one side of sclera to one side of the limbus to the other side of the limbus, right, is the horizontal white to white. Right, so these are considered biometric measurements, but of course for IOL calculations, axial length it's the most important that's taken for measurements, for calculations. In some of the formulas, they do use anterior chamber depth, lens thickness, and horizontal white to white as well. So we will cover formulas in another session, so we'll have a little bit more discussion about formulas in that session. But I wanted you all to understand that biometry, it's measurement of lengths of certain parts of the eye, right? So there are different types of biometry. You have applanation biometry, which is a contact type of biometry using ultrasound. Now this kind of biometry is not preferred because it artificially indents the cornea and creates a inaccurate measurement of the axial length. Usually measures axial length shorter, and as a result overestimate the IOL power, resulting in myopia, right? So immersion method, it would be preferred if you are using ultrasound biometry. An immersion method uses the same instrument but uses a added accessory such as a cup here, like a Prager shell, and you insert the probe in and then you fill it with saline, and actually the probe doesn't touch on the cornea surface, right? So this measures the axial length without artificially indenting it and creating a over correction in the IOL power. The best method, however, is optical biometry, which is used by the IOL Master as well as the LensStar machine. They use infrared laser beams to be directed into the eye and then reflected off. Now the reflection of the infrared light then allows the instrument to measure what is the axial length of the eyeball. And these are the common optical biometers that are being used, right? So this one is the IOL Master and this one is the LensStar. Now the advantage with the optical biometry is obviously not touching. So compared to this method, it is not indenting the cornea. Compared to immersion biometry, these two are very similar in terms of the final axial length provided. However, optical biometry has a little bit advantage in that it measures the axial length to the visual axis. Because the patient is looking into the instrument, we can directly measure the axial length to the macula, which is the visual axis, whereas with the ultrasound methods, we are always making a guess where the visual axis is. We may be measuring not the visual axis, but the anatomical axis of the eyeball. So that may not be as accurate as the visual axis axial length. The other thing about optical biometers is that it measures a little bit deeper to the retinal pigment epithelium as compared to ultrasound, which only reflects off the surface of the macula. So, however, most optical biometers have this calibrated to more similar to the ultrasonic axial length. So this would be calibrated more towards the immersion biometry method. So if you notice our lens constants that we are using for immersion and optical biometry, we are using the same lens constants, but for ultrasound applanation biometry, we are using a different lens constant. If you notice, the lens constant on applanation is lower because it needs to compensate for the shorter eyeball length that is being measured. Yeah, so this is just some printout from the IOL master, and you can see axial length is measured. ACD, anterior chamber depth, is also measured, right? So some information. Now, it's important to understand that ACD here is not the same as the predicted ACD that's mentioned here. This is what is provided as a lens constant value, so it's not a measured anterior chamber depth, whereas this is an actual measurement of the anterior chamber depth. OCT is another instrument that's being used, but this is not so much in application for cataract, but this is more to look at the macular health, the retina, the status of the retina and the macula, all right, to check if there's any kind of abnormality. So for example, AMD, detachments, retinal detachments, etc. Okay, so basically I've come to the end of the session. I think it's 1.5 hours, or it's 12:30 already. So
hi Melvin.
Are there any questions?
Hi Melvin, sorry, this is Hannah. So first of all, thank you so much for walking us through that so well. As I said at the beginning, this may seem quite basic for some, a nice refresher for others.
I've actually ended earlier. I've just finished this a little bit earlier. So are there any other questions? Any questions relating to what has been presented?
Melvin, can you hear me?
Yeah, Melvin, I had a question regarding Myers.
Sorry, I may miss your question. I've put my speaker on mute, so can you please repeat the question?
The question is, are there reflections from cornea?
Can you say that again? I'm sorry.
I'm asking Myers, when we say measuring Myers, are there reflection from cornea of the same light which is used?
Yeah, the Myers that I was referring to, they are actually from the manual keratometry, manual keratometer. So what happens is that there's some projection of this Myers. Myers are like some. Let me show you. Just give me a minute. Yeah, some reflections like this. Can you see my screen?
I can. So
Yeah,
this is reflection of what? The images which the instrument is projecting, or what?
Yeah, so you will see this through the instrument, so it's projected onto the patient's cornea. So you see this as like light reflections of the cornea.
Yeah.
Yeah.
Okay.
Yeah.
Also, you made a point when you say optical, that is more measuring the visual axis, while when it comes to the ultrasound, that is more to do with the any bio anatomical axis of the eye. So can you little bit more elaborate on that?
Yeah, so when we refer to the visual axis, what we're referring to is from the apex of the cornea all the way to the macula. So when the patient is fixating into the instrument, so for example, the IOL master and they are fixating into it, that gives you the actual measurement to the macula, because by fixating onto the instrument with the object in the instrument, we are taking actually the measurement of the visual axis, because the patient can actually fixate on that object in the instrument. Whereas for ultrasound biometry, you don't have a fixation point for the patient, so the patient can't really fixate on an object, right? But rather you are just applying the instrument onto the patient's cornea, and you cannot be certain that the patient is looking directly at the instrument. Yeah, it may not be as accurate as this one that requires the patient to fixate into the instrument.
Thank you. Thank you.
Yeah.
Hi Melvin, can you hear me? This is Hannah.
Yeah, Hannah.
Hi Melvin, sorry I didn't think you could hear me earlier. I was talking away at you and you couldn't hear me.
Sorry.
No, it's okay. Melvin, I just want to say thank you so much for walking us through that so well. We do have actually another question from Cindy in the chat, which was, hi Melvin, can you elaborate a bit more on orb scan?
Orb scan?
Yeah.
Okay. Orb scan is I think it's more of it provides some kind of aberrometry readings of the eye, and the orb scan it's a Bosch and Lomb aberrometer which they use for their laser treatment. What the orb scan does, actually interestingly, is that it does provide a measurement of the posterior cornea. So that's something different from what other keratometers are doing. So it does have some information of the posterior cornea power or the posterior cornea astigmatism.
Yeah, that's one of its unique points, isn't it? The posterior cornea.
Mm-hmm.
Yeah. Great, thank you. So we'll just put it out there. Are there any more questions from anyone still on the line?
Yeah, Melvin, I'm asking a lot of questions, but let me take this opportunity of asking one more. When we say manual and optical, especially when we talk about the keratometry, manual will be giving us the value of the curvature of the anterior surface of the cornea. That means K1, K2 we'll get. And when it comes to optical, you said topography will get us the curvature, where exactly is the astigmatism. So as per the understanding goes, even for the anterior surface of the cornea, the manual will also give us the K1, K2 and where the astigmatism is on the anterior surface. Is it right?
Yeah, I'm not sure if I understood your question, but are you referring to astigmatism on the anterior surface, or are you referring to posterior astigmatism?
No. So when I say manual is capable of measuring only the anterior surface of the cornea, right?
Yes.
It will give us astigmatism for the anterior surface, which will include the value and which degree the astigmatism is existing. Yep. Cylinder is there at what degree, right?
Yep.
But when it comes to topography, it will give us more for the entire corneal curvature, including the posterior, in case we are talking about Pentacam and Galilee.
Yeah, some unique topographers So we wouldn't call the pentacam a topographer. It's actually a different type of instrument. They are like a category that's called shine fluke imaging. So they don't really fall in. They may not fall into this category here. So yeah, that pentacam and Galilei instruments, or some OCT instruments even, they provide posterior corneal astigmatism measurements. Keratometry, whether it's manual, automated, or topography, the usual topography, they only give you anterior surface keratometry measurements. Now, corneal topography gives you the entire corneal power, the mapping of the entire corneal power, but it does give you a final K1 and K2 simulated value. So they will have a simulated K value that's given in K1 and K2, so just like how you have it on the keratometry, on your manual keratometry or auto keratometry. But you need to take note that those values are simulated values. They are not measuring the center cornea. They are extrapolated from the peripheral parts of the cornea to the center. And based on the extrapolated values, it gives you a estimation, or they call it a simulation, of the central corneal power in the form of K1 and K2 values, and axis as well.
Okay. But when it comes to any of them, whether it is manual or auto keratometer, both of them at least measure the very central part. So manual, it is measuring somewhere around 3.2 mm, and the automated ones, they are measuring somewhere around 2.5 mm. So the central, any which ways they are measuring. So why in that case the corneal topography will be extrapolating value from the periphery to the center? Because that the part which was measured was the center part. So why from the periphery to the center then?
Yeah, because the center of the cornea is not being able to be captured. So if they look at the technology that is used in topography, right, it uses Placido rings. Basically, these are LED lights that are being reflected off the cornea surface. And the center of the cornea, which you can see right here at the center of the instrument, you do not have any, the rings are not small enough to measure the center of the cornea. So, and at the center of this instrument, you have a camera that captures the reflection of the light from the cornea. So with that camera in place, there's no way you can measure the center of the cornea, unlike keratometers.
Thank you very much, Melvin. So what I have understood is, like, when it comes to keratometry, auto or manual, they measure the center, but when it comes to corneal topography, that is measuring the peripheral part and extrapolating the reading for the center. Is it right?
Yeah, that's right.
All right. Thank you very much. Thank you.
Thank you. Do we have any more questions before we close up? No? Okay. Well, two last points from me before we give you an extra sort of 15 minutes back on your day. First of all, thank you everybody for joining. I hope this has been beneficial. As I mentioned earlier, it's going to be quite basic for some, a refresher for others, and helpful for others too. As we continue to develop this program of webinars, you know, we're taking this day by day. If anybody out there would like to have a go at joining in on one of these webinars to serve either as subject matter expert, facilitator, if you have a general topic you'd like to share that is in your area of expertise, then please let us know. We'd love to partner with you to help further the education for the region. Also, just to highlight what we have coming for the rest of the week, more